Okay, I'm very pleased to introduce our speaker today, Dr. Tony Dicker. Some of you might have seen him on 7:30 last week. Tony graduated in medicine at Monash in 1985, and he was awarded a PhD by Queensland University for his research on the molecular biology of skin cancer in 2001. Tony started the Sunspot Clinic, Skin Cancer Clinic in Cheltenham 2005, which has expanded to 2 more locations in southeast Melbourne. I consider myself very fortunate to be on his patient list for the last few years. He's picked a few cancers on me and takes them out expertly, and after a couple of weeks you can't see where he's been. So he could have been, I think, a plastic surgeon as well as a skin cancer surgeon. So please welcome Tony to address us on skin cancer awareness.
Thank you very much. I have a lot of fun doing these sorts of talks. I like coming out and presenting publicly and talking about my favourite topic being skin cancer. And I was on holidays recently and I get told off, don't get sunburned out there. And I say, I'm only going to the beach so I can look at my future customers. I won't say the same to the audience here, I hope. So, this is what I want to talk about, and the skin cancer awareness and just what skin cancer is. But in particular this line, if it's changing, get it checked. The 7:30 report was actually about the ABCD rule of melanoma. If it's asymmetrical, if there's an irregular border, multiple colours, more than 6 millimetres diameter. They wanted to introduce E, F and G, which is elevated, firm and growing. And growing is covered by this line, if it's changing, get it checked. And I think that's one of my 2 most important rules that I use. A changing lesion and an ugly duckling. If there's something that looks different to the rest of the stuff on your skin, and if there's something that's evolving or growing in some way. So myself, I'm actually with the Australian Skin Cancer Clinics now. I've evolved to the next level from Sunspot, where I recently sold my businesses so I could take over a larger business, if that makes any sense to anybody. I'm not sure if it's a good idea or not. But I'm still consulting down at the Cheltenham Clinic as well and thoroughly enjoy doing so. So I'm paid by them, obviously. I'm also a fellow of the Skin Cancer College of Australasia, and I have an association teaching at the University of Queensland for a master's program for doctors there. My aim for this talk is to educate you about different types of skin cancer, so what they actually are, the dangers of some, and how to protect your skin. So people often confuse what a melanoma is versus what a skin cancer is, and that's the sort of thing I wanted to be able to present to this group. I love questions. So at any stage you want to stick your hand up and just clarify something or check something, I might turn around and say to you, oh, there's a hand already. As he passes a piece of paper behind him, no. Well, I also enjoy embarrassing some people sometimes, no. And it might be that I actually have that topic covered in a future slide, which I'll say that's coming up. But otherwise, very happy to take questions as we go through the morning. So what's the background? Skin cancer doctors in general are general practitioners, so a GP with a special interest, okay? And the way that's evolved is that the burden of skin cancer outgrew the existing structures in medicine. So traditionally you would go and see your general practitioner, who would then refer you to a dermatologist, who would confirm clinically the diagnosis and say, yes, that should be cut off, so they would refer you to a plastic surgeon. Plastic surgeon said, yes, I've been told to cut this off you, I'll book you into the day hospital, and 6 to 9 months later it sometimes would be before the actual lesion was treated. And as that burden of skin cancer increased through society, it flooded the system. And whenever there's some sort of blockage in a system, people find alternate ways around it. And the general practitioners got to the stage where, well, I can't find anyone who can manage my patient's burden of skin cancers in a reasonable period of time, I shall do it myself. And so these clinics started flourishing in Queensland in particular, in Sydney as well, as a pure numbers game. And so it's not a surprising thing to have it evolve. The initial skin cancer clinics for the 80s and 90s, there was a few cowboys amongst them. Not surprising, any sort of new entrepreneurial type of doctor might be happy taking a few shortcuts along the way. Thankfully, since that time, it has evolved into what it should be. There is a college to represent the group, but it's kept its main purpose of easy access. So your skin cancer doctor is a general practitioner with an interest in skin cancer. Okay, so there's some general practitioners who have an interest in paediatrics. They like seeing babies. They like doing obstetric care for deliveries of babies. They might have a special interest in asthma. Well, this is a group who will often do some general practice as well, but have a particular interest in skin cancer, and therefore educate themselves further beyond medical school and beyond the normal ways of a GP in how to manage skin cancer. So we deal with lumps and bumps of the skin. So I don't really get involved in rashes, is the best way to describe it. So despite my background was in dermatology training in Brisbane, but I stick with lumps and bumps rather than rashes. It's by medical practitioners, of course, although some of the models have started involving nurses, and we're taking a standard trained nurse and educating her in lumps and bumps diagnosis as a way of managing this burden of skin cancer we have in our society. And it's training in the diagnosis and treatment of skin cancer. But the real stuff. So skin cancer, there's three main types. Oh, perfect.
Before you move on, can you explain the difference between a dermatologist and a skin cancer specialist?
Yes, okay. So a dermatologist is someone who has first got their medical degree, done their normal hospital time as a junior doctor, enters a training program for dermatology, which is a 4-year training program. It's a 5-year training program now. And on completing all of their examinations, is admitted as a fellow to the Australian College of Dermatologists, and therefore the relevant government bodies recognise that person as a specialist. A skin cancer doctor may have done that sort of pathway, as I did. I did all of that sort of type of training, but most of them have gone through the general practice training program, learnt the art of being a general practitioner, which is effectively a specialty these days. So to become a general practitioner, it used to be you would finish medical school, maybe do a year in hospital and then go and put your shingle up. Now a general practitioner does a 3 or 4 year training program in general practice. And after they've finished their general practice training as a generalist, they then undertake extra training to become a skin cancer doctor. Does that answer the question? Yeah. No, I love questions, thank you. So, skin cancer is the general umbrella, and the main three types are melanoma, basal cell carcinoma, and squamous cell carcinoma. And I remember these in terms of, think about main capital cities. We have melanoma for Melbourne, the most evil of places. No, it's not. Basal cell carcinoma being Brisbane, very, very common up there. No. And squamous cell carcinoma being Sydney. So as you move further down in the latitude, it gets more dangerous. So the basal cell carcinomas are very, very common, but thankfully, it's extremely rare for someone to die from them. Okay, there might be 1, maybe 2 deaths a year from basal cell carcinoma. In contrast to melanoma, where we're talking about 1,500 or more deaths a year. If basal cell carcinomas were dangerous and killed people, we would have a specialty in basal cell carcinomologists, because that would be the most common cause of death in Australia by a long way. We're talking hundreds of thousands of these per year. Thankfully, not a deadly disease. It's what I call a nuisance cancer rather than a dangerous cancer. At the same time, we shouldn't just ignore them. They do other topics, which I'll delve into shortly. So, of the melanomas, to start with, it's a cancer of the pigment cell of the skin. Okay, so this is the cell that makes the colour to give you a tan, but also determines your background ethnic colour. It causes over 1,500 deaths a year. It only kills you if it gets to leave the skin. So if we find it early, when it's only on the skin and hasn't left the skin, and we cut it off at that stage, that's a cure. Our problem is that if I cut it off, I can't tell if one single cell had floated off the day before and is going to cause problems in the future. But the earlier we catch them, the more chance that it is all gone. So I describe it as learning how to swim. If you learn yourself learn how to swim, that's when we become dangerous.
What about the level 1 to 4?
Yes, so in terms of the levels on melanoma, that's a prognostic predictor of whether it's learned to swim or not.
Mm.
So a level 1 melanoma or a melanoma in situ, we know statistically they can't swim. So if we found every melanoma as a melanoma in situ, we could cure every melanoma. I'd love to achieve that. That's my life purpose, is to be able to work out a way of doing that. As the Breslow thickness, which is our measure of level 2, level 3, and level 4, increases, that's a predictor of the relative risk of having learned how to swim. Now, it's a predictor, it's not a yes or no answer. So we do have people who are diagnosed with a thick melanoma who go on to live for the next 40 years without any problems. And we have some people with a very thin melanoma where we're saying, these are pretty good odds, but unfortunately they still fall on the wrong side of the odds. That's where the levels of melanoma come into it. So our aim is every melanoma, if we can find it as level 1, a melanoma in situ, we can then cure it.
Well, can the pathologist inform you on the biopsy of the when you take it out, what level it is?
Yes, so the question about how we actually make this diagnosis, that is a pathologist diagnosis. So we look at it and we get an opinion of what we think it's likely to be, whether it's a thin or a thick melanoma. We actually rely on the pathologist to do the measurements, because the measurements are in points of a millimetre. So we might see a melanoma which is measured as 0.7 millimetres thickness. And therefore that's still regarded as a thin melanoma, but it's less than a millimetre thickness. Once they get beyond 1 millimetre, when we start talking about being thicker melanomas, and that's very much a histological diagnosis from the pathologist rather than a clinical diagnosis. So this gentleman's back, lots of interesting lumps, which I can assure you virtually all of those are harmless. But there is an ugly duckling there. There's one that just looks a bit different from the rest. It's a little bit darker, and it catches my eye certainly, and it will tend to catch your wife's eye. We get lots of men coming in with my wife noticed something on my back, and that's a reasonable degree of suspicion. I get very, very suspicious when a lady comes in and says, my husband noticed something on my back. His husband's never noticed anything. So that's a high degree of suspicion. But this lesion here is a melanoma. Again, a relatively thin melanoma. It's brown to black in colour, and it's the ugly duckling. It's the one that just looks a bit different to everything else. The rest of them all being little things called seborrheic keratoses, which I describe as signs of wisdom and maturity. Your wisdom spots. Proof that you're wise. This is actually the lady I was discussing on the 7:30 report, because not every melanoma is like that. This lady is 34 years of age. 8 years ago this photograph was taken, with a little pink spot on the side of her knee, which doesn't look anything much more than a mosquito bite. But this is actually an atypical melanoma. This fails that A, B, C, D rule that the media story was all about. It doesn't have the real clues. This one we got to diagnose because she said to me, I've noticed this spot and it won't go away. When I looked at it, I couldn't find an easy diagnosis to name it and say, oh, this is this sort of harmless lesion. So that combination of her saying, I've noticed this, was a very important part in saving her life. So she saved her own life. I just got in the middle and stuck a knife in and cut it out. But it was her noticing something and then doing something about it is why 8 years later she's able to appear on television and talk about it.
What level was it in here?
This was a level 2 and it was 0.3 millimetres thick. So a very thin melanoma. But there was no clues in my eye to sort of make me jump at it straight away. It's only when she started the discussion saying, look, I know it looks like a pimple, but it's been there for 12 months now. I said, oh, that doesn't work for a pimple, does it? That's the wrong sort of story for this sort of lesion. Which then got to the stage of, okay, well, I can't give you a definite clinical answer. Let's go to the next stage and let's take a sample to find out what it is.
Could I just ask you please, how deep do you have to dig into that skin?
So for this, yeah, it's that thick, 0.3 of a millimetre, not very far. What I do for this is I go down to the underlying fat layer. And I do so because that's where the skin moves. That becomes a cosmetic issue in terms of making the scale look nice. So rule number 1 is take the whole thing off. But rule number 2 is now you've got the whole thing, what's the best way to make the whole look good? And so for her, we went well below what the melanoma was because that's where the skin actually moves to close nicely.
And are these purely the result of sun damage?
Not all of them, and a good question. So sunshine is a very significant factor in skin cancer and melanoma, but not all melanomas are due to sunlight. So this one may have been, but probably not, because the rest of her skin around the area has got no real features of sun damage. And this was pink and brown, but also this girl here, you may recall from the news about 5 or 6 years ago, Claire Oliver. She's probably the reason why Victoria banned sunbeds, because she died of a melanoma at age 26, which spread to her lungs, which is why she's got the tubes in her nose. An Asian skin type, she'd used a sunbed 3 or 4 times. Unlikely that ultraviolet light and sunshine were the actual cause for her melanoma. She used her unfortunate death to do good, is one way we could interpret it, to remove a significant factor in causing melanomas, but it's not the whole cause. So sometimes genetics doesn't fall on your side of the table. So that's a factor in the whole thing as well. We also see the reverse. We see people who have spent their entire life surf lifesaving club, out being bronzed. All their photographs, they have dark coloured skin because they've been out in the sun when their natural skin was quite pale, who don't get skin cancers. And you think, how did you get away with that? So there's other factors beyond sunshine, but it's a significant factor, certainly. So history is important, and her history saved her life. Her talking about what's happened to her. It was something that had changed, and she said, look, this thing is just, it's appeared in the last 12 months and it won't go away, it's growing a little bit. And even then, if you, in retrospect, yes, it's an ugly duckling. It was a pink spot which didn't match any other pink spots on her. She didn't have 25 lesions on her skin that looked like a pimple. There was one pink spot which didn't match the rest. So those simple rules can have a significant impact in saving lives. Then you see things like this, and yeah, that's an ugly duckling. That's a big, large lesion. But in fact, that's been present since birth. That's a birthmark. And so the story pulls us the other way. It's not getting bigger, it's been there since birth, it's not changing colour, there's nothing evolving in this lesion, and it matches what a birthmark should look like. So things can meet the ugly duckling rule, but not everything is changing, not everything that looks odd is bad. It's our guide for which things to start looking at so we do find all the bad ones. I expect to see a lot of harmless lesions, and I want to see a whole lot of harmless lesions so that we don't miss the bad ones. So when people come in and say, look, sorry to annoy you, Tony, I know I was here 2 months ago, but this thing on my arm, I'm noticing it. I say, look, that is one of those wisdom spots. It's very safe, but thank you for coming in. If I see 19 of these, I'm also going to find one extra melanoma. That's what I'm here for.
Tony, what causes a birthmark and can you get rid of them?
So-
Particularly the ones that are on people's faces.
Yes, you can. So a birthmark is, again, a very general term. You can get a birthmark due to changes in the blood vessels. You can get birthmarks due to change in the pigment cells like this one. You can get birthmark due to other cells as well. So it's a very general term. Each individual type of birthmark has ways of being treated. So the blood vessel ones, for example, which is what we usually see on the face when they're red or pink or purple, the vascular lasers shrink down the blood vessels and therefore improve them. To get them to the stage of completely gone and very normal looking skin is quite difficult because there's underlying structural changes. But they can certainly be improved rather than removed is probably the best way to describe it.
Given that you're making a decision whether it's harmless or not, is there a legal requirement for the qualifications of the person assessing you in a skin cancer clinic?
Yes, but well, in Australia you need to be registered as a medical practitioner or at least under the supervision of a medical practitioner as a minimum. So if we train some nurses in diagnosis and that nurse misses a melanoma, the doctor who's responsible for them will be medico-legally liable. So I pay money every year to a medical indemnity company for that purpose. So we all take out individual medical indemnity for that reason, and that's where the liability rests. And in fact, if my receptionist does something which causes someone to have a melanoma missed, in some ways I'm still liable for what she says as well. To a degree, we can be brought in as being a culpable party in that sort of circumstance. So in terms of the level of qualification and who's allowed to do it, that becomes a determining factor who actually covers the insurance for it. In terms of the education, I could quite happily teach all of you how to diagnose melanomas. In fact, a lot of my patients do exactly that. They bring in their own skin cancer and they say, I've noticed this is changing, Tony, I've noticed this. It is some pattern recognition. It's a level of knowledge or a volume of knowledge that we gain over a period of time. It's not something special secret which only doctors are allowed to know. There's no secret handshake to learn this stuff. It's just knowing a volume of knowledge. So, as I've sort of suggested,
Is there something you can take that reinforces the area of the skin to give you more resistance? Like someone said vitamin B3 is good to reinforce it.
excellent. Yes, and that's near the end of the talk.
Oh, sorry.
So I'm glad you asked the question. So yes, there are things which help in the prevention side of things, which we'll cover shortly. Yeah. So yes, today is about the letter C, most good old Sesame Street days. C being for change. That's a really simple, easy clue. I'm expecting to see lots of harmless things as a consequence, and it's a good thing that we look at the harmless things as well. It minimises our chance of missing melanomas. We've got more chance of diagnosing them all early. If we diagnose them early, we can save a life. I love statistics. And the Australian Bureau of Statistics have some amazing figures available for those who want to delve. I'm sure some of you have as well. And so I have fun going into, probably fun's not the right word for this, but I have an interesting time going into the causes of death as published by the Australian government. And they show this. They show you the top 5 current causes of death in Australia. So heart attacks, dementia, strokes, lung cancer, pneumonia make up our top 5 as we expect. Okay, you can actually see from those figures how much of a problem dementia and Alzheimer's is actually becoming over the last 15 years in contrast to other things. That's a really significant health issue that we're now need to address. Part of the reason for that is because we're not dying of the heart attacks and the strokes and the lung cancer and pneumonia anymore. Because we've treated the other things, it's become almost an extra cause of death. Sorry.
You've just answered the
Oh,
question.
okay, good. Yeah, so that's a big factor in why it's evolving that way. But that's not the whole story. We can't just write it off saying, oh, just bad luck. No, it's a significant health problem we need to keep on working on. But that's not our talk about today. I want to put it into relative context. We hear about all these different things about this death and that death and how we can prevent all these things. working out apples and apples, okay? So yes, dementia is a much more significant cause of death compared to skin cancer. But if we look at breast cancer and suicide and skin cancers, they're all in similar sorts of numbers. And all three of those are slowly increasing still. So over the last 15 years, there still is an increasing number of actual deaths from breast cancer, despite all the advances in different treatments. So there's been some great improvements in the treatments, but the actual numbers are still going up. Suicide has been talked about a lot, and mental health has been talked about a lot, and it is a real significant problem. Actual deaths from suicide are still going up. It's not just the media getting excited about something, it is a significant problem in our society. But in the same way, skin cancer is going up as well.
They're absolute numbers. You've got a per capita comparative.
This is Australia-wide.
Yes, but in the population is growing too. So I'm not-
Oh yes, okay. Those statistics do exist. I haven't got them with me, I suppose, is the answer, but they are increasing per capita. So in terms of numbers per 100,000, they still are growing faster than the population. But that does shrink down the curve, certainly, it's quite correct. The campaign for the road toll is working, because compared to everything else, it's actually going down. Which is a fascinating thing to see, is that if you look at these curves graphed out over the past 10 years, the suicides, the skin cancers are still going up slightly. The road toll is starting to come down. The other things we talk about is gun control and drownings over summer, and they're right down the bottom in comparison. So in terms of relative risk, they're still important. A drowning of a 4-year-old is a horrible event, but in terms of the raw numbers of what actually occurs, it's a very uncommon event compared to death from skin cancer or death from suicide. And even still much less than the death from the road toll. And yet, gun control we talk about a lot. In fact, it's uncommon to be shot and die from a shooting in Australia for the head-on causes. If you look at drownings, what the surf lifesavers do, it's possible it's better for the surf lifesavers to pull people off the beach and put them in the water, stop them dying from melanoma. Maybe not. In terms of relative numbers, that's what's actually happening. They're sort of put back on the beach and they get missing cancer instead.
What's the age relationship for deaths from melanoma? Does it range right through, or does it peak?
It does slowly increase with age. So there's, in the population of 90-year-olds, there's more deaths per 100,000 people with melanoma compared to 30-year-olds. If you compare the same age group of breast cancer and car accidents and melanoma, then melanoma is quite high. So there is a significant number of young people dying from melanoma as well. So yes, it's not just a matter of, like dementia, people are getting old enough to get melanoma now. It's actually still is a young person cause of death as well. Yeah, so when you start comparing the risk of skin cancer and death from skin cancer versus drowning or gunshots, or snake bites, spider bites, eaten by a crocodile, all the things that the newspapers love to talk about. Struck by lightning is still a very rare event. They have some amazing statistics available. There's a statistic about cause of death being due to appearance and behaviour. So you can tell all the wives that no one's ever died from their bum being too big in the dress. Statistically proven. But yeah, they're just highlighting the difference in what the relevant numbers are to some of the other things that are talked about in the popular media. Seatbelts save lives. The decrease in the road toll is actually showing that, and what the campaigns have been doing has been fantastic. It has made a significant impact from what was happening back in the 70s, which was about our peak for road deaths per 100,000 people. And skin checks can do the same thing. If we're looking at the skin, we're getting these things diagnosed, we can find them early, we can dramatically decrease that number as well of deaths per year from skin cancer. That's what I do. That's my mission, my purpose, is how can we do that? Second type, let's get off the morbid stuff and talk about the common things. So basal cell carcinomas are what I see virtually every day.
Yes, could you comment on Hutchinson's freckle. I
Yes.
understand that's a pre-cancerous condition.
It's interesting in medicine how things evolve over time. So back in the 1970s, Hutchinson's melanotic freckle was a diagnosis of a pre-melanoma. That same lesion today on a glass slide in front of a pathologist is now called melanoma in situ. So it's exactly the same spot, we use different terminology for it now. We recognise it as an actual melanoma of early stage rather than a pre-melanoma as it was back in the 70s. Again, it's at that in situ stage, so it's curable in terms of if you cut off a Hutchinson's melanotic freckle, which is now called a melanoma in situ, you cure the person. There was a behaviour saying that's a pre-melanoma, we could watch it. And then a reasonable number of case reports came through where the watched pre-melanoma became an invasive melanoma and the person died as a consequence. So we decided maybe watching these things isn't a good idea after all. There's been more change in terminology as things have evolved over decades. So basal cell carcinomas are things like this. They're the most common form of cancer that we see in total. 1,000 per 100,000. About 1% of the population gets one of these every year. And that goes up with age. So as you hit the sort of 80 plus age group, it's about 80% of the population of Australia over age 80 will get at least one of these every year. That's a common problem. Okay? As I said, if this was a cause of death, even if 10% of those people died, that would be the most common cause of death in Australia. Thankfully, it's not the case. They grow locally, they rarely spread, and very rarely through the body, they just seem to cause local disease. Our problem is, we get simple little ones like this fellow's chest, a nice early stage, they're a little shiny, pearly papule, and we can cut those things off and they're easy to treat, and they're slow growing, they're locally invasive. But if we don't do anything about it, we can get that sort of thing. We can't leave them. I'll take that slide off, it's not a nice slide, is it? So we can't say, oh, it's a harmless skin cancer, do nothing. We can delay our treatments. Look, there's a little skin cancer, but you've got a holiday booked over in Europe for a couple of months. Let's see you back in 3 months' time, we'll cut it off then. That's safe. Okay? So it doesn't have to be done straight away. It's not something that should make you hit that big red shiny panic button on the side. But doing nothing is not a good outcome either in the longer term. Yes, I'm removing 3 or 4 of these a day. They're common items. They are definitely sun-induced. We see them in the more sun-exposed areas, so especially around face and ears and things, so the more cosmetically sensitive areas where we commonly see these things. And again, the smaller they are, the easier they are to remove, the smaller the scar we have to leave behind as a consequence. So I like finding these early and dealing with them in a simple, expedient way to get a better cosmetic outcome as a consequence.
With the carcinoma and melanoma, is the essential difference to a layman the risk of spreading with a melanoma as distinct from a carcinoma which doesn't spread?
Yeah, so off the word cancer, there's different subtypes of cancers. And so there's a carcinoma type of cancer, there's a sarcoma type of cancer. It's to do with their cell of origin. So a melanoma sort of fits into the category of a sarcoma type of cancer. But that's independent of the risk of spreading. So the risk of spreading is more related to the individual cancer itself. So a breast cancer then gets subdivided into subtypes, and that individual subtype we know statistically has a certain risk of then spreading. So there's some very aggressive types of cancer which frequently spread, and there's some other cancers like the basal cells which are extremely rare for them to spread.
What about solar keratosis?
Again, coming up nicely, ready for you.
Okay.
I'll move it shortly, certainly,
All right.
yeah. So that's our basal cell carcinomas, and again, what I call a pretty piss-weak sort of skin cancer. It's a safe skin cancer. We need to do something, but don't panic about it. They're straightforward to fix, is the nice thing. We've got time to play with. Squamous cells sort of fit in the middle, so we're sort of halfway between Melbourne and Brisbane. We're into Sydney. It's the squamous cells. And yes, these do still cause a reasonable number of deaths per year. We're in the order of about 300 or 400. So you might have noticed on the numbers, those who love numbers, that the skin cancer death rate's up around the 2,000 mark, while the melanoma rate's about 1,500. And the gap is the squamous cell carcinomas. So they're still significant, okay? They're causing a reasonable number of deaths. And they're much more common than melanomas. So we see a lot of these. Again, most of these don't cause a problem, but because of the sheer number of them, some of them sneak through the system and actually cause problems. They're often a crusted pattern. We've got some scale and crust. They're often sore. One of the big clues to me when someone comes in, I'm saying to them, these little rough spots, are any of these sore? And that's something that distinguishes the one spot, which is an early squamous cell, from the solar keratosis type thing, which is like a pre-cancer, which we'll get to shortly. So they can be a bit of scale on the surface. They can be very crusty. They can be smooth and pink. They persist longer than a pimple. So one of our clues when someone comes in a little swollen pink spot, if it's lasted more than a couple of weeks, that's not something just inflamed like a hair follicle. There's something else going on. They're usually on the sun-exposed sites as well. And they do need cutting off, is the right way to approach those. These precancerous lesions, good timing, we've got 2 slides. So actinic keratoses or solar keratoses are these little rough scaly spots you feel on your scalp and your temples and the backs of your hands. And they're a sun damaged spot, I call them sunspots, just for simplicity. And they've got potential to evolve into a squamous cell carcinoma, but they're a long way short of that. So I call them a pre-cancer. Most of them do nothing. Many of them actually resolve by themselves. They're daylight dependent in terms of the more time you spend in the sun, the more they evolve. But the reverse also applies. The more you protect yourself from the sunshine, they start going away. And I've seen that actively happen on some of my patients, some of those people who will still be up on the Gold Coast at the moment rather than having returned to Melbourne. They'll spend their summer in Melbourne, down at the beach on the peninsula, and they spend their winter up on the Gold Coast, walking on the beach up there instead. And they're cutting sort of 4 to 6 to 8 skin cancers off them a year in between their visits. And a couple of those people are finally convinced that maybe wearing a hat and a shirt could be a good thing. And after I've nagged them for enough years and they're sick of me sticking a knife into them, okay, I'll give it a try, Tony. And then they come back and say, oh, bugger, you were right. They don't like admitting that, but that's okay, I don't mind it. I'm happy at the end of the result is that you protect yourself more, these things go away. So I see more of these in summer than winter. So if I'm making a diagnosis of these sorts of spots, the solar keratosis in the end of winter, I'm saying, well, that's a persistent one of significance. Let's be a bit more aggressive to treat it. If I'm seeing these sorts of things at the end of summer, I'm saying, well, this might be just the activity of your skin. Let's give it a chance, hit the protection really well for a while. We get into a calmer, less UV type of time, these will actually go away. So we manage these based on how much it's affecting the person. Often it comes down to how much of these spots annoy you. That's a very individual thing. So I'm happy to let some of these just stay there if the person isn't worried by them. Or if they're annoyed by them, we do things like this, we freeze them off. That works quite nicely.
When you tell people to wear protection, a hat, what sort of hat do you suggest? Because so many people wear caps.
Exactly, yeah. It's great for me finding skin cancers on ears. As a push the ear out to make it look like Prince Charles. And I'm looking forward to Prince Charles wearing a skin cancer in his ear. It's quite useful, isn't it? Yes, I describe it as a broad brim. So one thing I say with hats is take the hat, hold it up to the sunshine. If you can see the sun through the hat, the sun can see you. So the loose weave hats with broad brims aren't having much effect because the sun can still get through it. But it's got to be practical. So if you're going to put on a hat and you're going to sweat and pass out from heat exhaustion, that's not much use either. So it's a compromise in many ways, but look for something that's going to block the sun, have a brim around it, is being more ideal.
Do you recommend particular sunscreens?
I do, and my line there is it should be 50 plus. It should be broad spectrum, but most important, it should be one you like. Because if I give you the best sunscreen in the world, and it smells a bit funny, and it's a bit sticky on your skin, it lives in the bathroom cupboard. And it doesn't work there. So often it is a matter of trial and error. Which ones do you like? Try 2 or 3 of them, which feels best on your skin. That's the right one to use, is how I approach that.
How many of these various melanomas and whatnot had their genesis 40, 50 years ago and they've just come to the
Yes,
surface
yeah.
now?
So skin cancer is not a one-step process. It's not a matter of one day a normal cell in your skin wakes up and says, oh, I've got skin cancer today. Skin cancers go to school. Okay, the cell on your skin is sitting there, it cops a dose of UV light, and one little thing changes. It's just past grade 1. And then it might have to learn the grade 4 lesson next from the next grade of UV light. That completes all its primary school knowledge, and it's sitting there with a couple of little subtle mutations, not visible on the surface at all. It's only internally in its DNA, which prime it to get to secondary school. And secondary school, a few more things happen. It's not just the cell itself, it's also your whole body. So your immune system has a big influence on what's allowed to keep on going and what gets knocked off. So if you've got some slightly abnormal cells in your skin, and you've got a very vigorous immune system, it might see that abnormal cell and says, I don't like you, you're out of here, kill it off. A good example is the renal transplant population. People have had organ transplants get a huge number of skin cancers. Not because they've been lying out in the sun, it's because we suppress their immune system so vigorously to keep the new organs inside them that other things start escaping around. So there's more than one step to becoming a skin cancer. So yes, you're right, your skin gets primed over the years, and what happened 40 years ago and what happened 30 years ago, so our sunburns as a child all contribute to the relative risk. But at the same time, right here now today, there's no skin cancers there. It needs the extra dose to tip it over the edge. So your ongoing sun protection now is also still important. That can stop them graduating, is the idea. So even though they're ready to graduate, if we don't give them the final lessons, they don't actually become skin cancers.
How often should one get a complete skin check? And what is the significance of mole maps?
Yep, 2 good questions. So how often is a very individual thing. So the way I approach it is a person comes in for the first time and I make it's subjective, but I make an assessment of their skin and say, this is what your skin's like compared to the cohort of people I've seen over the last 15 years. I put you into this sort of category. I think yearly's right for you. There's lots of things happening in your skin. We're cutting a few skin cancers off. I need to see you twice a year, so every 6 months. Some people I'm seeing every 3 months because I know that by the time I've cleaned up the current lot of skin cancer, the next ones will be growing. Others I'm saying, you've got great skin, I'm going to see you in 2 years' time. Or it might be, you're only 12 years of age, you've got normal skin, I'll see you when you're 25. So it's very individual, the average is about a year. In terms of the mole mapping side of things, it's excellent for a subgroup. So the people who've got 500 moles all over their skin, it's very hard to identify that one ugly duckling amongst 499 odd-looking moles. When you start taking images and comparing images year by year, that's when you suddenly see the new spot that's popped up amongst, that's the needle in the haystack thing. That helps that group to find them early. So for the group who've got hundreds of moles, that's worthwhile. For the group who've got lots of skin cancer history and growing lots of things, previous melanomas, that's a sort of subgroup where there's an obvious benefit for a mole mapping type thing, a series of photographs. For the general population, it's probably overkill. There's a nice component to have a series of pictures at the start. So I do take a lot of photographs, but I take photographs of areas of somewhere it's hard to see. So I take photographs of backs. So we've got a reference point for the future. I take photographs of things which have caught my eye or which you've brought in at the time because they're going to be there in the future to compare to. And then there's another group who doing a complete series of photographs of all this skin quite useful.
Sandy, what is the relativity to colour skin? Fair skin, dark skin?
I've never actually excised a skin cancer from an Aboriginal person. It does happen. They usually get the squamous cell carcinomas on their lips because there's less pigment on the lip compared to the rest of their skin. So the colour of the skin and the melanin is very protective for sun damage. At the same time, the typical behaviour in culture, I have been talking too long, haven't I? Is that they tend to seek out shade. So the mad dogs and Englishmen come out and play cricket all day in the middle of the sun. In contrast to their typical culture is they do things in the morning and the evening and then they'll stay in the shade during the middle of the day, which is a logical way to live in Australia. I'm going to keep on moving forward a little bit so we can get through our slide. We're not too far from the ends, I think. This is a really good guide about when you need sun protection. I've actually got this on my telephone, so I might just put it. At this very point in time, using the wonders of modern technology, I can pull up my little application, which tells me the UV index, and I know that the current UV index inside here is 0, and I have no reception to the hotel, is it? No, it is. So it's currently 6.8, okay? And that means that outside at the moment you should have sunscreen on, okay? So the UV index, once it gets above 3 is when you start considering needing sunscreen. And the UV index changes during the day, so first thing in the morning it's down at 0, it gets up to 0.1, 0.2, 0.3, 0.5, 1. So early in the morning it's a low UV index. Middle of the day is when it gets up higher. So the newspapers will quote when the maximum UV is going to be, but it's a good indicator of the relative risk at this point in time. That's how many rays of UV are hitting the ground at any one point in time, or per minute. At the same time, if you then spend 4 hours outside in low UV, you're just as likely to get burned as spending 1 hour outside when it's a higher UV. So sun protection was sort of covered with clothing, hats, shades, sunglasses, sunscreen. And who's had a chance to read the slide properly? I mean, we're all awake anyway. I've only got this slide here at the moment because everyone's sort of nodding off by now, but all these questions have kept everyone awake, I think, great. So, sunglasses are meant to have 2 S's, of course. And so now, of course, that I've put that sort of slide, everyone starts reading slides very carefully. Very cruel of the audience to do things like that and let us get so sweet we can't see it anyway. Vitamin D, and I'll talk about vitamin D3 quickly as well. Is getting very topical and very popular, and people come back from the doctor with being told they've got a low vitamin D. They changed the reference range. So going back 20 years ago, if you had a vitamin D measure, normal was regarded as being between 20 and 140. Now it's the low number somewhere between 50 and 80 and 140. And suddenly, oh, everyone's low. So they started talking about vitamin D insufficiency when you're on the lower side of the scale. That got too hard, but oh, we'll just say there's a cut-off when you're low. So there's a relative over-treatment of vitamin D beyond what it used to be, and it probably has swung too far in that direction. It'll come back again. I'm waiting to find out which large conglomerate company is going to make a lot of money out of this, but no one's put their hand up for it so far, is the funny thing, so I can't work out how it's really happened. Because it's a really cheap vitamin. It's not as if they're a new thing. We've had vitamin D tablets around for a good 100 years and they're only about $10 a box, so no one's making a fortune out of this. But 5 to 10 minutes, 3 times a week will give you your full dose of sunlight that you need to make the vitamin D you can make.
What exposure?
Again, so yes, you're right. That's why the range of 5 to 10. So you need a little bit longer at the start of the day, you need a shorter time at the end of the day. Hands and face, sorry?
Yeah. Just on the face.
Just hands and face, all you need. You don't need to take all your clothes off and walk around the streets.
Good.
Okay.
What is your opinion of the use of creams containing vitamin E on hard, dry bits of the skin, your ear and extremities. Is it worthwhile?
Yes, it's worthwhile. I'll cover that quickly. Any sort of grease is good for your skin. So when you've got dry skin and scale, then a moisturiser works, whether it's sorbeline or bio oil or vitamin E. The magic ingredients don't do much extra. It comes down to texture and feel. So vitamin E is good because it's a cream. I'll keep on going. So along with vitamin D, also I want to talk about vitamin B3. That's been quite recent. In the last 5 years, there's been some really good long-term studies talking about vitamin B3 decreasing actual skin cancers occurring. So people who get a lot of skin cancers, a lot of solar keratosis and rough spots, if they take 500 milligrams of vitamin B3 twice a day, their actual rates of skin cancer start dropping down. There's some good studies now showing that out of Australia. The fake tan's not so important for this audience, but they're safe. They're a really interesting story. They started off as artificial sweeteners. And as they're doing the trials of different cups of tea, people say, oh yeah, that works, that tastes like sweet tea. And there's a little stain of a moustache across their top lip. That's why they didn't use the product on return instead of other ones. So skin check we have actually covered in terms of how often individual things like that. It means I should stop there because the bell has gone. It wasn't too far over, I apologise for that. How long do we have for questions? We're 12 o'clock, aren't we?
Well, gentlemen, I think we've heard an excellent exposition.
Very, very good.
Any more burning questions? Not sun-burning questions, burning questions. Yes,
Is there
Lloyd?
time for this question? In terms of the general population, is information available that would compare the prevalence of skin cancer 100 years ago as at today?
How far does information go back? Not easily. We haven't got great records of that sort of detail about causes of death. It's there, but again, like the Hutchinson's melanotic freckle, we regarded that as a pre-cancer 40 years ago. We now call it a cancer. Our interpretation of causes of death has changed. It's certainly a lot higher prevalence than it was 100 years ago, definitely.
So that